The UK social domestic care industry, faults and failings. Introduction. The social domestic care sector in the United Kingdom, the myriad of unpaid carers, home care agencies, care homes, domiciliary support workers and the local authority systems that oversee them, sits at the intersection of compassion and commerce. For millions it offers dignity, safety and support in later life or during illness. For many others it is a hand-to-mouth system that leaves people exposed to neglect, exploitation, theft and, in too many cases, physical and psychological harm. This essay is a sustained critique of that industry, its business models, workforce problems, regulatory failures, commissioning and funding structures, and the human consequences when these things go wrong. I include anonymized and composite case examples, theft from patients, assault, medication errors and prolonged neglect, to show how system weaknesses cascade into individual harm. The critique that follows does not deny the existence of conscientious, skilled and committed care workers and managers. There are many who do excellent work under difficult conditions. But goodwill alone cannot paper over chronic structural failures in a sector that is underfunded, under-inspected and heavily privatized. The evidence base for systemic problems in adult social care is strong. Official regulator assessments, sector research and investigative journalism have repeatedly flagged worrying trends in inspection capacity, oversight, and the concentration of poor outcomes among for-profit providers. Care Quality Commission +1. Fault 1. Chronic underfunding and brittle commissioning. One of the most fundamental faults is financial. Local authorities have faced sustained fiscal pressure for decades. Adult social care budgets have been squeezed even as demand has risen with an aging population and greater complexity of need. The result is a commissioning environment where councils seek the cheapest provider able to accept a care package rather than the best one. This tender-driven market rewards low-margin, high-volume models that can cut corners on training, travel time, staffing levels and quality assurance. Where price competition dominates, there is less headroom for recruitment, low pay, insecure hours and minimal training, all of which feed into poorer care. Home care workers rushed from call to call have no time to notice subtle health deterioration, to administer medication carefully, or even to lock away valuables properly when vulnerable clients' cash and cards are left in their homes. The downstream outcome is predictable: more incidents, more complaints, and ultimately a shifting of costs back to the NHS through more avoidable hospital admissions. Official analyses and sector reports have repeatedly shown that demand is rising while supply and investment are not keeping pace. Care Quality Commission +1. Fault 2. A precarious workforce, low pay, high turnover, poor oversight. Staffing is the engine of care. Yet the workforce is precarious. Low pay, zero-hour contracts, variable shifts and limited career progression make retention difficult. High turnover means less institutional memory, more inexperienced staff, and a dependence on agency nurses or temporary carers who may be unfamiliar with clients' needs and household routines. Where supervision is thin, line managers are overstretched and training skimpy, the risk of mistakes and misconduct rises. A common, pernicious consequence is poor adherence to medication regimes. Controlled drug mismanagement and basic errors, missed doses, double dosing, failure to document administration, occur in services where staff are rushed or insufficiently trained. The regulatory and professional frameworks that should prevent such mistakes are sometimes not enforced vigorously enough, especially when inspection capacity is constrained. The Care Quality Commission, CQC, and other bodies have documented unsafe medication practices as an ongoing problem. Care Quality Commission +1. Fault 3, regulatory weakness and inspection gaps. Regulation is supposed to be the guardrail of quality. But significant failings in the regulator itself, inspection backlogs, inconsistent judgments, lacking clinical capacity, have been repeatedly highlighted. There are persistent reports that many home care providers have not been inspected for years. Independent analyses found that a high proportion of small home care firms had never been inspected or had not been looked at for 4 years or more. Where oversight is uneven, providers with poor practice can continue to operate for prolonged periods before enforcement occurs. The Guardian +1. Compounding this, the regulator has been the subject of its own reviews, with recommendations for reform and urgent operational fixes. A regulator that cannot reliably inspect, rate and enforce is a regulator that cannot deter negligent or abusive behavior. The effect is a loss of public confidence and a landscape in which risk migrates toward the most vulnerable, those who cannot advocate for themselves. Fault 4, marketization and the for-profit concentration of failure. The privatization of care, particularly the dominance of for-profit chains, is correlated in multiple analyses with a disproportionate share of serious failings. Investigations have shown that most care homes forced to close for endangering residents were operated by private firms, not public or charitable bodies. Profit motives can create incentives to minimize staffing costs and delay capital expenditure on facilities, both of which materially affect care quality. While private firms can and do offer exemplary care, aggregated data show a worrying pattern. Serious negligence and abuse cases are disproportionately borne by institutions operating in a marketized environment where public oversight struggles to keep up. The Guardian. Fault 5, fragmentation of responsibility and blurred accountability. Who is responsible when care fails? The answer is often everyone and no one. Commissioning, provision and regulation are split across bodies with differing incentives and limited powers. Families are left to navigate complex complaints systems. The police, health services and local authorities sometimes operate in silos, leading to delayed investigations and a patchy response to allegations of theft, assault or neglect. Perpetrators who are staff can move between providers without adequate sharing of risk information, compounding the chance they will offend again. Anonymized case vignettes, how systemic faults become personal harm. Below are anonymized and composite case examples constructed from recurring themes in public reports and investigative accounts. They are fictionalized to avoid naming individuals or specific providers but are representative of documented failings. Case O, Mrs. B.'s missing savings, theft and financial exploitation. Mrs. B., late 80s, lives alone, moderate dementia, received home visits from a small private agency under a local authority contract. Visits were routinely scheduled at 30 minutes. Staff were expected to travel between clients with no paid travel time. Over 1 year Mrs. B.'s family noticed small sums missing, cash withdrawn from her purse, items vanishing from the pantry, unexplained charges on her debit card. Because Mrs. B had limited capacity, she did not complain. The agency's rotas were inconsistent. Staff often changed and there was no requirement to log when staff had access to keys or to account for valuables. When the family raised concerns with the agency, responses were slow and defensive. The local authority took months to review the case. By the time an internal investigation occurred, the staff member implicated had left and joined another agency. Criminal investigation was hampered by poor record keeping and a lack of CCTV or corroborating documentation. This vignette illustrates multiple problems: underpaid and transient staff susceptible to financial temptation, inadequate oversight of access to clients' homes, delayed and fragmented responses from commissioning bodies, and poor information sharing that allowed suspected perpetrators to move on. Had there been stronger auditing, mandatory reporting and faster multi-agency coordination, the series of small thefts might have been interrupted sooner. Case B, Mr. K.'s bruises, assault and failure to detect. Mr. K, mid-70s, had limited mobility and required assistance with personal care. A relative noticed bruising and a change in behavior, withdrawal, reluctance to let carers assist, and unexplained agitation. The agency supplying carers had recently undergone 2 managerial changes and was struggling to cover shifts. Staff told relatives the bruises were due to falls, and no meaningful investigation was launched. Documentation in the care notes was inconsistent, different staff used different shorthand, some entries were missing entirely. Only when a visiting nurse noticed repeated unexplained marks during a routine wound check was the escalation triggered. By then, detailed timelines had been lost. The staff member suspected of rough handling had received only minimal supervision and a single session of online training on moving and handling. There were no body maps, no photographic records and no follow-up safeguarding meeting for several weeks. This vignette highlights how poor training, inconsistent record keeping, and the absence of robust supervision create blind spots. The caregiver's alleged assault could have been detected earlier if there had been an institutional culture of reporting, regular spot checks, and prompt safeguarding practice. Case C, medication error leading to hospitalization, clinical neglect. A middle-aged woman with Parkinson's disease received home care for medication administration. The provider used an electronic MARCH, medication administration record, system, but staff frequently logged medication as administered without direct observation, effectively signifying completion when an electronic tick was pressed. On a weekend, a night carer, covering multiple clients, missed a controlled medication because it required a double signature and an out-of-hours GP had not authorized a substitution. The result was deterioration and an emergency hospital admission. An audit after the event revealed the agency's staffing ratios did not allow time for careful administration, training on the MARCH system was cursory, and the local practice nurse had not been routinely communicated with. Again, shortcomings in workforce planning, rushed calls, inadequate training and poor inter-agency communication combined to produce potentially avoidable harm. Case D, institutional neglect in a small care home, systemic failings. A small, rural care home was part of a private group. After a period of financial strain, the home reduced non-clinical staff and deferred maintenance. Residents reported cold rooms, missed meals, and staff who were always in a hurry. Families made repeated complaints which were rebuffed. The home's last public inspection was several years prior. The regulator's data systems had not flagged risk due to incomplete information. When a deeper investigation finally occurred following a whistleblowing disclosure, evidence of widespread neglect, inadequate nutrition, and poor record keeping emerged. Forced closure took months, during which resident well-being continued to decline. Advertisement. Privacy settings. This composite demonstrates how market pressures, weak inspection cadence and inadequate transparency allow poor standards to persist. The closure process itself was disruptive and traumatic for residents and families. Common themes from the vignettes. Across these anonymous examples, patterns recur. Time pressure and rushed calls, where carers are expected to deliver complex tasks in short windows, errors and omissions become routine. Poor record keeping, Inconsistent or falsified notes frustrate investigations and conceal trends. Inadequate training and supervision. Online tick box training without practical supervision leaves staff unprepared for real situations. Weak safeguarding escalation. Delayed or fragmented protection responses lengthen harm. Financial incentives misaligned with care. Low margins incentivize cutting corners on staffing and quality assurance. These are not isolated anecdotes. They reflect systemic features documented in regulator reports and sector studies. The result is that the very people who should be safest in their own homes or in care settings, often older, frail, or cognitively impaired, are left exposed. The human cost, dignity, confidence and the fear of being harmed. Beyond physical injury and financial loss lies a deeper harm, the erosion of dignity and trust. Victims of abuse often withdraw socially, decline further services out of fear, or experience increased anxiety and depression. Relatives become hypervigilant, exhausted from chasing answers and navigating bureaucratic systems. The NHS bears costs too: more emergency admissions, longer hospital stays and delayed discharges when safe domiciliary care cannot be secured. The social cost is harder to quantify: diminished quality of life, lost independence, and the corrosive effect of being treated as a series of tasks rather than a person. Research and sector bodies emphasize that many older people prefer to stay at home for as long as possible. But when care at home is unreliable or unsafe, the choice is hollow. The policy aim of enabling independence becomes a token aspiration unless the system can guarantee safety and dignity. Why current safeguards are insufficient. Several entrenched issues blunt the effect of existing safeguards. Regulatory capacity is stretched. The regulator's inspection frequency and the quality of its judgments have been questioned. Many providers, especially small home care agencies, have gone years without inspection. This creates a time window in which poor practice can become entrenched. The Guardian +1. Fragmented responsibility. The split between commissioning and provision encourages a lowest price wins mentality. Complaints processes are complex, multi-agency safeguarding is often slow. Information failure. There is no effective national register of misconduct that is sufficiently used. Moving staff between providers without clear information sharing allows risks to be displaced rather than managed. Underinvestment in prevention. The system prioritizes episodic crisis management, hospital care, emergency safeguarding. Prevention, better training, more meaningful inspections, investment in workforce development, receives less attention and funding. Market incentives. For-profit motives can lead to persistent underinvestment in staffing levels and capital. Investigations show a disproportionate number of closures and serious breaches are among private operators, underscoring that marketization brings risks that regulation has not yet neutralized. The Guardian. What can and should be done? Practical reforms. A meaningful reboot of domestic social care requires policy changes, funding shifts and changes in practice. Below are practical, evidence-informed measures that would mitigate many of the harms described. Increase funding and change commissioning practices. Fund care at a level that allows realistic staffing, paid travel time between calls, and proper training. Move commissioning away from a pure lowest bid model to one that pays for quality and sustainability, including environmental and staff well-being metrics. Stabilize the workforce. Improve pay and terms to reduce turnover. Create clear career pathways and accredited training that combine classroom and in-work supervision. Ensure that mandatory induction includes practical supervision and that competency assessments are verified by independent auditors. Strengthen inspection and regulatory capacity. Ensure regular inspections of all providers, with proactive risk-based scheduling and rapid follow-up when concerns are raised. Invest in the regulator's data systems and clinical expertise so that inspections are meaningful, timely and consistent. Financial Times +1. Improve safeguarding and interagency working. Create rapid, well-resourced multi-agency safeguarding teams with protocols for immediate protective measures, clear time frames and designated case leads. Standardize record keeping, for example, mandatory body maps for injuries, photographic records with consent, to facilitate investigations. Tackle financial abuse proactively. Introduce routine financial safety checks for those with cognitive impairment, better guidance for family carers, and stronger tracking when staff have access to keys or cash. Commissioning contracts should require agencies to have clear policies and audit trails regarding property and money. Transparency and public reporting. Make provider performance data understandable and easily accessible. Families should be able to view inspection histories, staffing ratios, and complaint outcomes. Providers with frequent or serious incidents should be publicly identified until improvements are verified. Regulate corporate behavior. Where care is delivered by large corporate chains, regulatory scrutiny of corporate governance, financial practices and reinvestment of profits into care quality should be mandatory. Enforcement powers should include naming and shaming, fines proportionate to turnover and, where necessary, accelerated closure processes with robust resident protection plans. Empower service users and their families. Provide clear advocacy routes and independent advocates for people who lack capacity. Make it straightforward for complaints to be escalated, and ensure whistleblowers have protected channels and rapid responses. The limits of quick fixes. None of the above are quick or cheap. The long tail of underinvestment and marketized supply means that incremental tweaks will not suffice. In practice, governments have to choose whether social care is an afterthought or a core public good. If the latter, then sustained, ring-fenced funding, a serious workforce strategy and regulatory reform are essential. Expecting current providers to deliver high-quality, accountable care on the margins of austerity is unrealistic. Conclusion. The UK social domestic care industry is at a painful crossroads. The demand for care is rising, yet the infrastructure underpinning safe, dignified care remains fragile. The evidence is clear: underfunding, precarious employment, inspection gaps, the marketization of provision, and fragmented accountability all contribute to adverse outcomes: theft from vulnerable clients, physical and psychological assaults, medication errors and prolonged neglect. These harms are not rare one-offs but the predictable outcomes of structural weaknesses. The anonymist vignettes in this essay are not horror stories invented to shock, they are composite reflections of patterns flagged by regulators, advocacy groups and investigative reporting. The remedy is not merely punitive action against individual carers or providers but a systemic rebalancing: better funding, better careers, stronger regulation, clearer accountability and genuine transparency. Without that, the sector will continue to rely on the goodwill of a workforce doing extraordinary things on too little, while the most vulnerable pay the price. If the United Kingdom is serious about care that upholds human dignity and prevents harm, then policy must move beyond slogans to sustained investment and structural reform. Otherwise, we should expect more families to find themselves repeating the lines in these anonymist cases: and to pay, emotionally and financially, for a system that failed to protect them.